Welcome again to another episode of the School of Airway. This is Dr. Torres. Today we're going to talk about Case 1, Ketamine, used for procedural sedation. Patient had presented with a shoulder dislocation, young, in his late 20s. He's just schizophrenia and bipolar. So luckily he wasn't depressed, and that's not the reason I used ketamine. I wanted to use it and see how he would do with it. I had propofol ready, just as a backup, because sometimes people with ketamine do not relax and they need some type of additional sedation. This is my version of ketofol. Right? Ketamine up front provides some analgesia, disassociation. I'd fallen into the trap that the myth of ketamine does not cause apnea. Found out the hard way. So it had end-tidal CO2 connected through the nose with a special apparatus to the wall, to the monitor. Gave the ketamine quick. Luckily he had the nasal cannula. No oxygen connected. It's connected to oxygen, but it was on 0. Alright. I'm watching. Patient consented for the procedural sedation and for the closed reduction. And magically I'm watching the patient and watching CO2 monitor, and I watch it go from breath, small breath. I'm looking if he's still connected to it, and oh my God, he's not breathing. Go to the wall, connect to high flow 15 liters. Do a bilateral jaw thrust. Maximize the hose through the nose. Now look at the monitor, and respiration occurs. So later on I found out if you push it real fast, it may happen even if you push it over 1 minute. You may have to push it over 2 or even longer ketamine to make sure this acute dissociation of the brain to the lungs and to the heart does not occur. It helps you to do procedures, painful procedures, but it will cause acute transient apnea and hypoxia if you don't watch his respirations. If I had waited on oxygen only to drop, that would have been a scary thing, because there's a lag, and he probably been apneic 30 to 45 seconds or even longer before that if I'd waited for the pulse ox. That's why I don't connect high flow oxygen or 2 liters to 3 liters of oxygen. I use that as a backup. The drop in the SAT is second. The waveform for hypoventilation on end-tidal CO2, very essential. He stayed alive. He did have some weird emergence phenomenon, but didn't act out. He had a flat affect and said it looked like he was getting pulled apart into many pieces like a puzzle and getting reconnected. And he was watching us doing that to him. But he tolerated the procedure. I did have to give him propofol. The apnea did not occur with the propofol. After he survived the apneic episode with the ketamine, we gave doses of propofol. Instead of 1 milligram per kilo, half of that winds up being almost 40 milligrams at a time, because the ketamine did not relax him completely. He didn't have any moaning or pain, but his muscles, instead of relaxing, had increased tone. And the propofol was given aliquots of 20 milligrams afterwards every few minutes, and he tolerated the procedure and the shoulder went in. Okay, so ketamine is not perfect. It can actually increase tonicity of the muscles instead of relaxing for allowing reductions of joints. Okay, have your end-tidal CO2 monitor on these patients, especially if you push ketamine. Do not believe the fallacy that it does not cause hypoventilation or apnea. It will happen if you push it real fast. Okay, IV especially.